you are joining, just let me talk you through some functionalities of our webinar today, which is taking place in Zoom. I'm sure you know those, especially who usually attend us. So you have at the bottom the toolbar, and you have two buttons which will be important for you today. It's the chat button, and I can see that you already discovered that. Thank you very much for typing and introducing yourself in the chat. Also, there is a button of Q&A. You can ask questions to our speakers today using that button. And also, let me remind you that today we're having translators. And if you need translators, you can also shift and use that button at the bottom. And welcome, welcome. Thank you very much for introducing. Please use the chat actively. We always like that. And today we are going to discuss a very interesting topic. Actually, we were looking forward to it because we do understand it's a demanded discussion for many of the medical facilities, and not necessarily only outpatient facilities, but also hospitals that have outpatient departments. It's how to effectively measure waiting times. So time waits for no one. Time waits for nobody. We all understand that. And today, let's discuss this very, very burning topic. And we do hope that you will like it. You will be also actively participating by asking questions, raising certain concerns, and also you will get answers to all your questions, and also will be able to improve your waiting times in your facility. So first, before we start listening to our first speaker, I actually wanted to share one slide as well. And I hope you see my screen. And why we decided to talk about waiting times? Why did we choose this topic? Because in IFC benchmarking, I hope you can see my slide. It's a little bit slow sharing. Let me know if you can see it. Can you? Okay, I think I'll stop sharing because I see black screen, and try share once again. Apologies. So why we chose this topic? Because I think you can see my screen now. Because there seems to be a very logical thing that busy outpatient departments will always have longer waiting times. Yeah, that's what we all expect. And that's how we kind of justify ourselves being medical facilities. Yeah, when patients complain, we understand what can we do about it because we are busy. We cannot manage it. But in IFC benchmarking results, an interesting thing was observed. And here you can see it being summed up on the slide, that some organizations actually were able to achieve high OPD utilization and low waiting times. And this is amazing, actually. These are amazing results. That's why we thought that we definitely need to discuss this topic today. And we actually invited companies that really succeeded in managing their waiting times, and we wanted them to share their journey and their experience with you. Maybe you will be inspired by this, and also we do hope that you will start thinking about implementing certain changes in your facilities as well. So let me now introduce our first speaker today, and this is Aisha Saudi from Echo Group. Aisha, the floor is yours.
Okay, thank you, Julia, for having me. Thank you, everybody. Good afternoon, good morning from the different locations in the world. So very quickly, I would be sharing my screen on what I would be presenting today. Okay. Okay, please confirm that you can see my screen.
Yes, we can.
All right, great. So thank you once again. My name is Aisha Amira Saidu, and I would be representing EHA Group. So basically, EHA Group is a group of 3 companies. EHA Clinics, eHealth Africa organization, and also EHA Impact Ventures. So, in summary, EHA Clinics is the primary healthcare facility based in Nigeria with about 4+ locations across the different states. eHealth Africa is the NGO arm for EHA Group, and then also EHA Impact Ventures is an investing company for women-led businesses. But for the focus of this presentation and this webinar today, I will be focusing more on representing EHA clinics. So I'll be taking us through our presentation, and this presentation will come up as a story, and basically just taking you through the journey that we've been working on since 2022. And in background, EHA Clinics, like I said, is a primary healthcare organization where we focus on primary healthcare services. And with that, it means, we run mostly as an outpatient facility. And because of that, understanding that this is a bottleneck for most outpatient facilities, where we need to look at our wait time consistently and seeing how we could get, that full on satisfaction for our patients, right? And also at the clinic, we also look at quality and patient safety as our as our topmost priority. And because of that, we run a lot of quality management system, which I lead in ensuring that, we execute continuous improvement activities across the organization, and also looking for ways that we can always improve our productivity, see more patients, of course, and also see how we could reduce waste. So we also run a lean operating model, which means that we consistently look at ways that we can improve our systems, improve our processes, and cutting out waste. We also have our JCI accreditation and also ISO accreditation at the clinic. It just keeps us on, of course, on top of our feet when we look at, how to sustain quality management system across the organization. So without further ado, I will just take us through what this presentation is about, which I mentioned that is a story where we look at, how we're able to improve our wait time at different years, at different stations, and how we're able to go about that. So basically where this all began is 2022. So because of the fact that, we always have to sustain, quality, we had a very high turnout of patients complain. Patient complaining that they've waited over an hour before seeing just a doctor, right? You can imagine how that would be a pain in the neck, right? Because when you come into a facility, especially for a healthcare facility, most of the time when you come in through that door, there are a lot of things that you may have to do. First of all, you have to check in. You have to now see the nurses for the nurse to take your vitals. Then you see a doctor. Sometimes you have to go through the lab. You go through the pharmacy, and then you still come back and pay your bills. So we can imagine how much of a headache it was for our patients, where they had to wait for over an hour to just see the doctor, especially. And you can imagine that means that they'll probably be staying for about 7 hours in our clinic. And we understood that this was a major crisis for us, and we had to do something. And, we had to look at, ways to really cut out the waste as much as we can. Of course, this affected our patient satisfaction scores that we usually would track on a monthly by monthly basis. We also missed our 10-minute benchmark, because ideally we were supposed to also just, stay at a 10 minutes benchmark for every stage. So ideally this person, patients that were complaining to stay for about 1 hour should have just stayed for about 10 minutes. Then also our physician workflow was broken, right? So there wasn't, efficiency in how our doctors were seeing their patients. So we looked at, ways to obviously, really look at all these issues and see how we could come up with sustainable solutions. And of course, running a lean operating system like ours would mean that we would obviously deploy, looking at how to cut out the various lean waste in our system. Some of few things that we looked at, brought up some root causes, which I would also be taking us through. Looking at no appointment management policies. So when we gathered around, we sat down, we thought through about the process and what the issues were. We understood that, appointment management policy was an issue, right? Also, we had a lot of cluster scheduling, so no buffer time. So the scheduling were coming back to back. Obviously, would even cause burnout for our physicians as well. No, our clinic workflow was inefficient, and also our staff-patient communication had some gap. And then also we had a doctor per duty on peak days. So imagine coming into, as a doctor and you have like, almost 20 patients to see, already that's already a stressful time for that doctor, or even more than 20 at some point. So we looked at deploying different lean tools, and we thought about the PDSA. Now, what is a PDSA? The PDSA tool is just a structured methodology that allows you to continuously improving in cycles. So it doesn't stop at one cycle. It just means that when you have your team seated, you're all thinking about how to keep on improving your system. So you would have like as many PDSA cycles for one problem. So understanding that, wait time is something that we can't really resolve at one point, right? There's always something that would come up. So the only way that we can consistently see that we're improving would be to deploy a PDSA approach. So PDSA for short just means, P means plan, D means do, study, S means study, and then also A means act. So at the plan phase, this is where we define the problem, we analyze our root causes, we set smart goals for ourselves, and we design what we want to experiment, right? Now think of it as a pilot, right? It's just something that you just want to experiment. So you're not thinking to actually get something for perfection at the first time. Now you have the do phase where you pilot all these tests that we've said. So you look at different tools. So we looked at different tools to also use to sort of pilot the test experiments that we've set for ourselves. Then study phase, we put in a period of how long we want to test it. And we consistently were tracking the data. So our patient satisfaction data, also the time that it takes for someone to come in through that door to see a doctor. Then we compared it from the actual result, actual data that we had and what that planned data would be. We identified our blockages and we shared our findings. Then we acted on it. So ACT just allows you to understand, okay, we put in all this improvement work. Does this mean that we would need to have a next cycle? Of course, because like we said, wait time is here to stay. As many patients that you have in your facility, your wait time keeps on, being affected. So we have to consistently improve. So this is where we acted and understood that we had to continuously have, cycles within the day. So I'll take us through what we did in our first PDSA. So we looked at it from an A3 approach where we had all the different teams sit down. So we had from the medical, the nursing, and the operation team running their A3 project. So basically what A3 improvement project helps you to do is, like we said, look at, root causes, propose solution, put in time-bound targets for ourselves, and then see how this obviously our system. So what we did is we formed those teams. We use the fishbone analysis to diagnose our root causes, and then also we looked at mapping out the full patient journey. Something that I mentioned at the beginning, where it starts from when that patient comes in, when he checks in, the lab the billing, and then all the different stages that that patient has to go through. And then, of course, looking at how we could identify the different waste at the different points that this patient gets to see a provider. Now, the key finding that we found from this was, of course, as like I said, our patient satisfaction score was pretty low, and then it was really driven from our long wait times. So as of the time when we're done with this improvement project, our 2022 win showed that, we're able to have an agreed 10 minutes benchmark, because at the point we didn't really have like a benchmark as to what we wanted to set for ourselves. Then also, we also built a cross-functional QI capability. So we understood that, teams have to talk together, teams have to interact. So we sort of sustain that quality improvement capability across the clinical team. And then also we generated the different structural solutions that people can also book appointments to avoid that overcrowding. So there were things around, booking telehealth. So telehealth means that, of course, patients can see doctors at the comfort of their home. So they don't necessarily have to come to the clinic. That usually would reduce overcrowding. Then we redesigned our appointment system and also provided a billing officer role. So that billing officer helps in terms of hastening up, billing, especially when the patient has to check out. So follow on that, we understood that we also had to continuously check in our data. And of course, that's really gave us some bit of improvement, but we understood that we had to do more. So follow on to 2023, we kicked off our cycle 2, and the cycle 2 just showed us, a little more. So of course, we're able to improve from a 2022 to 2023, but we still had 65% of our patients still reporting over 10 minutes to access care. And remember that, of course, as a clinic, you have, we launch a lot of new services and we have more people. So that could have been, the reason why we still had this many percentage of our patients still reporting this, and we had to sort of go back to the drawing board again. Now, we looked at the different percentages. On an average, it was a 65%. And then some of our intervention that we tested was then we needed to create our appointment management policy. We needed to also put in a buffer time to our scheduling system. We also needed to have that shift modification to allow the doctors to also breathe before seeing the next patient. So in order not to avoid burnout. And also we obviously had to educate the staff on the new appointment booking system. And also, we employed that patient communication on our reception screen. So on the screen now, patient had visibility of how many patients were walking through the door. Also anonymous, just to point that out. But then basically, it gave them visibility of how many patients were in the system. Because the way our work through is, most of the time when you're at the front desk, you don't necessarily know what is happening at the different stages. So it just helped, in terms of anxiety for those patients. And then, of course, we also use social media and our mailing list to share more information on how we're able to tackle these challenges. So in 2023, after we were able to put in all these adjustments, we saw a lot of improvement. Our 65% reduced all the way to 41% in August. And also, it sort of rose up to 44. Remember that I said we keep on looking at data and we keep on translating our data, right? And of course, what drove our August drop was, those necessary measures that we had put in place to ensure that, we're able to get to our final benchmark that we had set for ourselves. Now we move to our cycle 3, right? I can imagine how you feel like this is already stressful, like, it's never ending. And this is really how we see it, because if we preach continuous improvement, it means that we are consistently improving in all our practice and our system. So at 2024, we tested our, cycle 3. And interestingly, we just focused on the department because it looked like from our patient data, our satisfaction data, pharmacy was a bottleneck at the time. Patients kept on waiting so much, right? We said 10 minutes, but we had patients waiting for over 26 minutes just to collect their medication. So we looked at all the different areas in terms of efficiency. Some of the root causes were our stock out rates. We looked at, poor shift handover between the pharmacists, and then a lot of manual work was being done for one person. So a lot of billing, and obviously this would now account for a lot of billing delays for the patient. And what we did was we individualized our stock tracking sheet per pharmacist. We made sure that we had an out of stock benchmark, which we set and we're tracking monthly across our locations. And then we had that mandatory handover notes that pharmacists have to. So the verbal only handovers was eliminated completely, and we kept on running in parallel all our, pharmacy team A3QI projects and looking at our appointments data as well. Now in 2025, of course, after doing all of this, going back to just 2024, we put in all these measures, but then we still had, a bit of gap in terms of getting to where we wanted. So of course, we had to put in another PDSA cycle as well. So in 2025, that was when we got our first breakthrough in Kanu. And this was a major, major accomplishment for us, because imagine something that you've been doing since 2022, right? So 2025 was a major breakthrough. We celebrated ourselves and were able to meet our benchmark of 10 minutes, which was even less to about 8.2 minutes, right? We did a lot of, this was like an overhaul of a process revamp for us as well. And of course, also embedding lean in how we were able to revamp this process. So what we did across that was, first of all, we looked at our process flow revamp, of course, using the spaghetti diagram and the full process analysis of our clinic workflow. We looked at non-value adding steps, right? We sort of even looked at, how do patients come in from that door and how do they get across? So do we want to change it? So rather than allowing patients to move around, do we want them to sit just in one space and we come and meet them? That was a better flow for us. We piloted that, of course, looking at it that this is a new process and we needed to pilot. So we did a pilot and that really helped us to achieve our goal. Also, we had that visual management that we deployed, right? Just to ensure that we alert our staff if there's any dashboard deviation. So basically, the staff were also alerted so that they're able to address potential outliers as it comes. Then we also employed the Gemba work, which is a structured work where we have leaders run through this flow, look at the different gaps so that the leaders can also look from the doctor's lens, right, and the patient's lens. And this also brought about a lot of root causes that we validated on the ground. We also looked at our quality and patient safety connection to our strategic goals. So we ensured that we're consistently looking at, what these goals mean to us, right? And then how are we able to define our break periods? And then how are we able to improve our documentations? Then, of course, we standardized our process, ensured that we did a lot of communication even to our patient care providers just to understand this new process. Also, we ensured that involved a lot of tech and booking fix. So at EHE clinics, we also do a lot of technology infused systems. So in terms of building our EHA care appointment system, so we have our own inbuilt EMR, which is called EHA care. That also gives us the opportunity to really adjust the system, and this is something groundbreaking for us. So we were able to use that to of course introduce that appointment system where people can make their appointment online. They can also just call if they want to, but then very seamlessly online as well. This obviously reduced that booking delays for us. And then that policy that we had created enforced, a lot of system improvements. So that's basically what we had done. And this just gives us a holistic picture as to what we were doing relentlessly for 4 years, right? 4 PDSA cycle. But we just had one thing in mind, right? Where we're able to get patients to have that timely, high quality care across our locations. So, what we'll tell ourselves in 2022 when we started this is, of course, data is very important, which is paramount for you to be able to really continuously improve. You need to have that data. You need to have your first line data. You need to keep on consistently looking at how to analyze and how to look into that data. Gemba is non negotiable, right? You cannot redesign a process just from a boardroom. You have to look at what is really going on that floor, what's going on from the patient perspective, what's going on clinical lens. Then also ensuring that everybody is involved. It's not a one-man job. So we had to ensure that all the clinical teams own their A3 improvement project and got it done. We also celebrated our micro wins. I mean, in 2022, even the improvements that we done, we celebrated them. So at every point in time, every year, we were celebrating our micro win, even at the same time that we were unable to get to our target, but we still celebrated our micro wins. And of course, that culture of continuous improvement is very important. Now, because we run a lean operating model, it was easy for us to embed this into our staff to always continuously improve using A3 improvement projects. And of course, understanding that the patient is at the forefront. The patient is who we are designing it for, and we have to always ensure that the patient's feedback is also embedded in our design, as much as possible. So that's basically my presentation. I hope you had a very good understanding and understood, why we did this. And of course, just using the theme of this webinar, which we say time waits for no one, which is very important. And neither did we. We stood up, we ensured that we started with our data, we walked the floor, we engaged our teams, and we celebrated our wins, and we never stopped cycling. And just to, on a final note, this doesn't mean that we have stopped, even at the point that we've gotten to our benchmark. We are still cycling, and we probably would have as many PDSAs as we have. Thank you so much, and I'll stop here for any questions.
Thank
Thank
you.
you.
Thank you very much, Aisha. And let me remind everyone that we will have a dedicated Q&A session towards the end of today's webinar. So I must say it was a wow story, Aisha, because I also worked in a healthcare facility. We were also struggling with waiting times, and also we were having multiple facilities in our network, and some of them were really facing great problems with waiting times because they were very busy. And that's exactly refers to the first slide that I showed today. And actually, certain things that Aisha said today was really music to my ears. First of all, waiting time improvement is really a kind of controversial problem because on the one side, unfortunately, there is no one size fits all solution because bottlenecks for each facility will be very unique. They will rely on many factors, on the whether you use EMR, whether you have appointments or walk-ins, what type of services you are providing, how many staff you have, and lots of other things, local community specifics, diseases in the local community, and even culture of the local community, because some patients prefer walk-ins, some patients like to make appointments, so lots of factors need to be taken into consideration. But at the same time, there is a very good thing that unifies all the facilities. It's the journey. The journey would always be the same. And it was music to my ears to hear how tools of root cause analysis add value to this process. Actually, I think it made all our audience change attitude to this tools if they are not using them yet, and also start thinking about doing so, because specifically for waiting time and identification of this bottleneck, they are super useful, and the journey and the approach, this is something that would be common for all the facilities. So the findings will be different, but the journey can be definitely borrowed, and you can definitely be inspired by what Aisha told us and start from the same point as it was mentioned in the year 2022 for EHA group. So, and also I think today our discussion is super important because if we're talking about customer care and customer care service, waiting time probably would be number one complaint for in many countries globally. But speaking about quality and patient safety, not only it's part of customer care, it also can be potentially dangerous. And there were some questions about it, about triage, because some patients in the outpatient department just cannot wait, because they need some help urgently and they might deteriorate. So they need to be assessed as soon as possible. And this is another potential risk, and this is another potential push to start managing waiting times. I'll stop here, and I'm happy to introduce our next speaker today. It's Dr. Karina Lukac from Regina Maria. Okay, Dr. Karina, the floor is yours. Over to you, please.
Thank you. Good afternoon. Thank you for your invitation. I will share my presentation in a minute. Okay, so this is okay, great. So first of all, I will tell you a couple of words about Regina Maria. Regina Maria is a national-wide network with 6 hospitals, multidisciplinary hospitals, and a lot of outpatient departments, laboratory, kinetic department, dental department. I will tell you some things about the department, the outpatient department, about the emergency care department that we have in our hospitals, and something about a new pathway about oncologic patient. First of all, I want to add that two of our hospitals are JCI accredited. So we learn from their standards too. I am a doctor. First of all, I'm an internal medicine doctor. But now I am also a quality and patient safety director, and I take care of some locations in the west side of our country, of Romania. Uh, and let's start my presentation. We will discuss today about redesigning patient flow, reducing waiting time across care pathways. In all our network, we have a feedback system that is in place since 2018, I believe. And we analyze the data that are obtained through this system. We understand that patients that are waiting, they are not just waiting. They experience uncertainty, lack of communication, and loss of trust. So for us, this was a very, very big deal, and we tried to solve this problem. The patient journey, generally speaking, has some steps that are efficient, but we understood that the overall journey becomes fragmented and slow. The patient has an initial consultation. The consultation happens quickly because we have a system that separates the activity of doctors in hospital in the outpatient patient department. So when the doctor is in the outpatient department, he has only the consultation. He has no hospital activity. So the consultation happens quickly, but there are needed some additional investigations, like, for example, an EKG for cardiology, a spirometry for pulmonology, and so on. And the patient waits for the investigation, for imaging, for laboratory, for to do those required investigation. And then the patient comes back for the follow-up consultation, and after that he has an answer and the treatment. But we applied this pathway and understood the fragmented situation for each of our three domains we were talking about. For example, for outpatient department, before the consultation, we tried to reduce the preparation before each. So the EKG and the spirometry are performed before the appointment. The patient comes in our clinic, and he is distributed to a nurse that has to perform these investigations, and after that he goes to the doctor. In the emergency department, the main delay was waiting for results. So rapid clinical decision via point of care testing and reserved imaging slots. Let me explain. When the patient comes into the emergency department, he has a triage. And in our country, the triage is something that is defined by law. In each department, we have to do the same things. So the triage happens quickly. The patient is distributed in one level of severity, and then he or she goes into the emergency room. There, he is consulted and he needs something. For example, a laboratory test, or a CT scan, or MRI, or an ultrasound, more frequently an ultrasound. So we tried to minimize these steps. We put there a point of care system, and every blood samples are um, uh, they are done there, so the results come in very quickly. For the imaging department, we blocked we reserved some slots, so when the patient needs, we can go with the patient in the imaging department, and we can let them there to do the investigation without interfering with the other patients that are that have an appointment and that have booked an appointment already there. Another situation for our country are the oncology patient. And here, the fragmentation is the main delay. And we tried to, and our target was to obtain a diagnosis within 14 days. For that, we had a patient navigator. The patient navigator reduces delay between steps, and he ensures that the patient is not lost in the system. This patient navigator stays connected with all the doctors in order to understand each step. And also, the patient navigator is connected with the patient and help him understand what he has to do. Our patient navigator is also a doctor, so he understands very, very much the medical situations and the medical meaning of each result. These are the steps that I've explained you. We introduced, but they are more clearly presented here. So for the outpatient department, we introduced pre-consultation investigation. So in this case, the consultation becomes a decision-making, sorry. Okay, here. The consultation becomes a decision-making moment, not a data collecting steps. The emergency department, we have faster results, faster clinical decisions, and so a faster solution and a faster treatment for the patient. We also here regarding the imaging, I forgot to explain you that besides the dedicated imaging time slots, we have a prioritization of emergency imaging requests. So the doctors that are on duty, they read the imaging performance with prioritization for the patients that are in our emergency department. Oncology, as I've told you, the navigator, the patient navigator, and we now I can say that we obtained that the time to diagnosis is to 40 days when we are measuring from the first presentation in our network, from the first system and for the first systems that the patient declares. In conclusion, we have now the waiting time. Understand that is a system issue. Is not quite a scheduling issue. We tried to address it, and we obtained some good results. Different patient pathways required different solution, as I've mentioned, the emergency, the outpatient, and the oncology. Small delays between steps create major impact on the patient journey. When we are thinking that at the end of the patient journey is his health and his treatment, we believe that every delay is very, very important. We also used different type of analysis, and we also used different source of information from feedbacks from our colleagues, from our nurses, and everybody collaborate to minimize these delays between steps. Faster decision improve both patient experience and clinical flow. This is well known, and coordination is very, very important, and is as important as the capacity of the system. I can say, and I believe that you agree, better flow creates better care. Thank you.
Thank you. Thank you so much, Karina. I think these were really great examples of improvements, and I think some of them were really eye-opening. Like, for example, I think it's a great solution that certain investigations are done before the visit to the doctor, which actually makes the whole experience of the patient inside the facility much shorter. Yeah, instead of 2 visits before and after, just 1 visit to the doctor with all results ready, and decision-making process becomes really, really fast. And actually, it also answers already some of the questions that we are receiving in the Q&A. For example, about how to manage waiting time in the diagnostics, because not always certain things can be scheduled, of course, like, for example, appointment with the doctor, which is usually the first step. But sometimes we cannot predict whether a specific patient would need a lab test after or not, or would need an X-ray after or not. And you often, or usually, it becomes a bottleneck. And this is one of the things that is very difficult to manage, is unexpected diagnostics, how to solve this problem. But we will talk about it later, I hope, in more detail during our Q&A session. First of all, I wanted to say that thank you to our speakers who already spoke today. We received great feedback in the chat that the presentations are very insightful. And also thank you very much to our audience for being so active, asking your questions in the chat and using the Q&A. Please continue doing so. We will have our session for Q&A towards the end of today's event. Also, I wanted my colleagues to share information about other IFC initiatives apart from healthcare quality that we're talking about today. Waiting time is also part of healthcare quality. So ethical principles in healthcare. I kindly ask my colleagues to share the link in the chat. So if you are not yet subscribed to this initiative, you want to learn more about it, please follow the link. It's for free. And we do believe that it will make your life better and life of your patients as well. And also, I kindly ask my colleagues to share a link to IFC Community of Practice on Facebook. If you are not part of the Community of Practice yet, please join. We do believe that you will like it, because there we actually do almost the same. Peers share their experience, peers learn from each other. And we believe that in healthcare, it's one of the most valuable things when not only you solve your problems alone, but also you look how others are doing it. And sometimes you don't need to invent a bicycle, because there are ready-made solutions that you can just borrow and implement. And now we are moving to our third speaker, Joe Mauti, who used to work in Health Quality Ontario. And Joe will also share his wonderful presentation on the same topic, managing patient waiting times. Joe, you're welcome.
Thank you, Julia. Thank you for inviting me. I'm happy to be here today to share some of my experience as a quality improvement advisor. I'm not a clinician. I work with healthcare teams in Canada, specifically the province of Ontario. And my work is based on 15 years with our provincial quality advisory organization called Health Quality Ontario. So today I'm going to spend 15 to 20 minutes. I have more slides than time. So see, we already have a demand exceeding supply problem. But here's what I'm going to focus on, and let's dive in. So we're all talking about access to care. Um, Access and timeliness of care is one of the 6 dimensions of a high-performing system that the Institute for Medicine first talked about in 2002. Delays are common in North America, specifically in my country, as we're hearing delays are common everywhere. Nobody likes to wait. In Canada, we wait to see our family physician, we wait to get a diagnostic test, and we wait even more to see a specialist. So waiting not only affects our happiness, but it affects our ability to heal from our illness. And sometimes it increases costs because the longer the illness continues, it requires more intervention. But also sometimes people go to see 2 different healthcare providers for the same reason. So our Aisha and Karina talked about all their efforts to make the system better. And so I believe that quality improvement is about making things better in a methodological way, consistent, and it's not a job that just requires 5 minutes of your time and then you put it to bed. It is continuous efforts to try and make something better. I like this definition by the people at Dartmouth College. They said everybody who works in healthcare really has 2 jobs. One is to deliver the care, and the second is to look for opportunities to improve care. So as you go about your work to make something better, you have to be very cautious that you are dealing with humans. And some of these humans love their traditions. They have some long-standing habits and deeply held assumptions. So as you go to introduce change, you need to be aware that some humans might resist the change you have. But in order to achieve improvement, all improvement requires change, but not all change leads to improvement. So that's why I was happy to hear both Aisha and Karina talk about the importance of studying your system, understanding root cause, so that you can identify the solutions that might have the best chance of success. My points today, the theory I'm presenting today, are due to this gentleman. His name is Dr. Mark Murray. He studied as a family physician in California in America, but then he also worked as the director of ambulatory care at Kaiser Permanente. He was the first one to apply the queuing theory principles to access in healthcare. So I learned directly from him in a training session. We spoke on the phone many times as it applies to specialty care. I want to warn everyone that I'm not here to criticize healthcare providers. Reducing waiting times is about managing flow. It is not about asking people to work harder. So that's the most important thing that, and I think our previous speakers have said, that it is about systems, how a system is designed. So let's talk a little bit about queuing theory. It is the science of waiting in a line. It helps us to understand why waiting happens, and it helps predict how long a wait is going to be. Then, as improvement specialists, it can help you decide how many people or machines are required to keep our system waiting lines short. So let's look at a simple example. I have a fruit stand in my home community. People arrive every 2 minutes. That equates to demand. The rule for serving people is first come, first serve. Those of you that work in emergency have a different rule. It's probably based on priority of who is sickest. On average, the one clerk takes 3 minutes to serve a customer. So that one clerk represents supply. So in an hour, the demand is represented by 30 people. However, only 20 can be served. So my question to you is, what happens to the other 10 people? So like in healthcare, in this fruit stand, people will wait. And every hour, the wait grows longer. So the owner of this fruit stand has three choices. One is to do nothing and allow people to wait. They run the risk that maybe they go to the competition where there is no waiting. Two, they can look to increase supply. They can bring in another clerk. However, like in healthcare, that adds more cost, something they have to decide if it's worth it. The other thing they can do is look to reduce demand. Now that's funny because this person is probably trying to make a living. So maybe rather than use the word reduce demand, we're going to talk today about shaping demand. We'll talk about that later. So here are the 6 principles of access. These were, like I said, created or developed by Dr. Mark Murray. I don't have time to go in depth to all 6. I'm going to focus a lot of my time on number 1, which I feel is the most important. So advanced access is something that was called the editors when Dr. Murray started publishing. He said, we need a sexy name for this concept. He didn't really like the word advanced access. It could be sometimes in the literature, it's referred to as same day access, day of choice. But what's important for you to understand is it was first developed and applied for primary care providers. In North America, we define primary care provider as a person responsible for the comprehensive health care of an individual from the moment they're born to the moment they die, cradle to grave, we call it. It is a philosophy, not a product. It's a belief that people should be seen without delay. So I'm talking about the time it takes for a person to get a scheduled appointment. We measure it in days. The metric is called third next available appointment. It's how many days away from today can a person calling to get an appointment receive not the first available slot, not the second available slot, but the third. We use the third because it's a more reliable indicator of access. So again, specialty care, I define as an outpatient department or a clinician who provides a specific treatment for a specific reason. They, in North America, typically get a referral from a family physician. Now, specialty care is different from primary care, but the principles I showed do apply. The issue with specialty care providers is they don't have as much time in the office because they have other duties that they need to abide by. So in primary care, I have coached many teams where they can get to 0 days. What that means is a person calls today, they want to see their primary care provider, there's availability today. Not because it was carved out. That what I mean by that is it was artificially frozen and released today, but it's available because a practice has balanced their supply with demand. In specialty care, the goal is not 0. It's not possible because, like I said, the specialists have other duties. But definitely you can improve waiting time. So how can access to care be improved? It's important to understand the relationship between demand and supply. How do we do that? Well, you can measure it on 2 levels. One is retrospective. You can look at and on an annual basis, how many appointments are requested by your patients in a given year. In primary care, we call that panel size. But perhaps in outpatient departments or specialty care, you might use the word caseload. And so you count how many people request an appointment and how often do they come back for a return visit. That represents your total demand in a year. You compare that to the total supply. How many appointments do you offer in a year? And how many days do you work to see patients in a year? So that is total supply and total demand. You can also measure it on a concurrent or prospective basis. I say daily. So what does that look like? So I'm talking now for specialty care. You would say every day someone in the clinic would record how many people call or come in for a new appointment each day. That's for a new visit. Then you would also record each day how many return appointments are requested or booked each day. Together, that number represents total demand. You would compare total demand to the supply you offer each day. Now, this is not how many slots are in the schedule in theory. It's actually how many slots were used to see patients. Sometimes you might have 6 slots, but then the provider has a meeting they have to go to, or they have a lunch and learn like this webinar, so they don't see it. So it's important to be truthful and record how many actual slots are available to see patients. You look at those numbers. You look to see how does demand compare to supply. If it's balanced, what I mean by that, if you have enough supply to meet the demand, but people still wait to get an appointment, then you have a problem with backlog. And your job is a little easier. You have to try and eliminate that backlog. Another way to understand the relationship between demand and supply is to collect and monitor data on third next available appointment. This chart represents real data that we collected with a diabetes clinic. On the horizontal axis, we have time measured in weeks, and on the vertical axis, we have days. And you could see in the beginning, there was backlog, probably because people were on vacation. But then this diabetes clinic had enough supply to match demand. Why do I know that? If demand every week was greater than supply, then the run chart would go up and to the right. But what we see is that over from week 7 to week 20, the measurement hovered around the median, which in this case is around 10 days. So it's measuring and graphing your third next available appointment is very important. Here's a quick example of how to measure the third next available. Here's a typical schedule. All the slots in blue represent appointments that are already booked. All the slots in yellow represent the appointment slots that are open and available to book. So on Monday morning, the person responsible to count this metric, it's important that you always count it every week on the same day, same time. So on Monday morning, they look for the third next available. It occurs on Thursday. So Thursday is 3 days away from Monday. So the TNA that week is 3. That's very fast, and you're going to get these slides later. So hopefully you could track that yourself. Now, if you are not in a balanced position, you have something to do. If demand exceeds supply, you could look to increase the supply of visit. Again, this doesn't mean work more, 7 days a week. Some of the previous speakers spoke about looking at what it is we do, who's doing the work, are members of the care team being utilized to their fullest capacity. You could look at different ways to deliver the work. Something in North America is called group visits using technology. I think Aisha talked about OTN as a virtual option to see patients. Another option you have is to reduce demand. Again, a better word is shape demand. Some of these points are more applicable to primary care, but let's say in specialty care, one conversation you can have is let's say the return visit usually is every 2 weeks. You can have a conversation to say for certain people, can we extend that to 3 weeks? Can we extend it to 4 weeks? Combing the future schedule is an opportunity to see, let's say Joe Mauti has an appointment today at 2 o'clock, but the provider says, I see he's coming in next week as well. Is there an opportunity to do next week's visit today? So that way you can save the future schedule appointment for another person. The other item on this list that's important for specialty care is developing service agreements with the referring parties. What does this mean? So again, let's say an orthopedic surgeon has certain criteria to determine eligibility. They get an agreement with the family physicians who send the patients to them to say, listen, I need the following information in order to determine. I need an x-ray. I need to know their weight. I need to know their age. If I don't have this information, then I can't determine their eligibility. So I shared an article with the folks at IFC, and they'll share that with you after today's talk. Another principle is to reduce appointment times and types. Again, in specialty care, I recommend you only have 2 types of appointments in your schedule, a new visit and a return visit. The more different types you have in the schedule creates different cues for each appointment, and that only contributes to the overall delay. So going forward, your job is to offer the supply that matches the demand. What this looks like is, again, you would have 2 appointment types in your schedule. You have to figure out the ratio of new visits to return visits. Let's look at an example that describes what I mean by that. Again, at the end of the year, you look back in your statistics and you see that 600 people were screened for a mammography in that year. Of those 600 people, 10% were called back for a recall. And of that 10%, 2/3 had to come back for a biopsy. So we look at this data to determine what the total demand was. The total demand represents 700 patients. 600 were for the first visit, and 100 were for what we call return. So the ratio is 6-to-1. This converts to roughly 86%, which is 6 divided by 7, of all appointments should be allocated to new visits. That way, you're matching your supply to the demand that's available. So then in this example, if my appointment slot has 80 appointments, 11 are dedicated for return visits. Let's look at what we could use this information for. Here is a concept of pooling demand and pooling supply. Perhaps these specialists, I call Dr. A, B, and C, let's say they're orthopedic surgeons, they could be oncologists, they could be obstetricians, or they could be different diabetic clinics. Now, perhaps they schedule individually. There's an opportunity to better match the demand with the total supply if they agree to work as a team. So we can see that the total supply is 30 units and the total demand is 32. If we scheduled appointments individually, the wait would continue to grow each week for 2 of the 3. However, a team approach would see one schedule with the 3 providers, and we would allocate the ratio of new visits amongst the 3 physicians. This way, we continue to working as a team. So the providers have to agree, let's match, let's combine our total supply. So that way, as a request for an appointment comes in, the scheduler doesn't schedule by individual provider, but by the team schedule. So the red hashtag here represents the ratio of new visits. So let's say it was the 2/3. So if they have 30 visits together, around 20 to 21 for all 3 would be for new visits. And let's say one week, Dr. A is at a conference learning about how AI is going to solve all our problems. If you want to maintain that pace, then the 2/3 has to be distributed amongst the 2 remaining individuals. Otherwise, the wait continues to grow. So I'm doing this quickly. I apologize for that, but I want to leave time for answers. The other principle is that this, like we've heard already, is not something you can just address one time and then go on to the next project. It requires constant attention, constant contingency planning based on the season, based on how the providers have take time off for education or vacation. It really requires a coordinated effort in the clinic to ensure that the demand is being matched by the available supply. So I've gone through these 6 principles very quickly. But again, my intent is to give you some key points of how it can be applied in your setting. There are challenges, as we've heard. Nothing, if it was easy, everyone would have done it yesterday. It requires a dedicated group of individuals to persevere. You need patience. Not everything is going to work right the first time, but through a collective effort, it's amazing what can be accomplished. At that, there are also 5 principles of efficiency. So, not only is it important to reduce the amount of time people wait to come into your office, but as we've seen from some of the 2 previous speakers, Aisha and Karina, that it's also important to be efficient once they arrive. And you'll get these slides that cover some of the issues that they've already presented. So with that, Julia, I'll stop.
Thank you so much, Joe. I think it was super interesting, super educational, and also very insightful and eye-opening as well, because it demonstrates a really interesting scientific approach, how to measure, how to approach actually, waiting times. And also, I think it gives food for thought, because I saw the great comment in our chat. Yeah, we should differentiate, and George just mentioned that, between waiting time to get into the clinic and also waiting time inside the clinic. So it seems it's kind of different things, but if we analyze, we understand that it's actually all are links from the same chain. And for example, if you don't manage your appointment system properly, patients cannot make an appointment at convenient time, they just walk in. And then you need to manage them inside the facility. They also wait. They also ruin your practices by just coming unexpectedly. Yeah, and they also complain. So it creates a kind of vicious circle. So probably managing your appointment right and giving them opportunity to make appointment at desired time would be the best early step to start approaching managing wait times management. So I think I just wanted to conclude what our speaker said today, because before we move, to the Q&A session, and also wanted to mention a couple of admin things after that. So just to conclude, managing appointments is definitely very important. Team approach was mentioned several times by our speakers, and that's so true. Nobody can solve these problems alone. You need to work together with your team, and ideally invite patients as well, because they are on the other side of this barricade, and they also understand and see things from a different angle and can provide you with great feedback. So this is number 2. The team should use the tools, various root cause analysis tools, and we received lots of questions about it. And thank you very much to Aisha and other speakers who already responded on these specific things. So using the tools and using the scientific approach, for example, that Joe described, will definitely be beneficial for you to identify the real causes, the real bottlenecks, which, as I said, will be unique for every facility considering the context. Educating patients, because there is also resistance, and Joe mentioned that, and thank you very much, because it is an important point. Not always solutions are well received, the facility solutions, because there is specific culture among patients, and they're just accustomed to certain approach, and they just prefer certain approach. So it has to be very delicate work with the community. So before we move to Q&A, just a couple of admin things. So we talked a lot today about quality principles and tools, etc. And I just wanted to remind our audience that in IFC, we developed and continue to develop online training modules, which are for free. They are available on online learning campus of the World Bank. I kindly ask my colleagues to share the link. You can visit, see what are the topics, and there will be more modules posted there. So please go there regularly to check. They are recommended for every staff member in the facility, and there is certificate issued after you perform the test. At the end of the module, they are self-paced, so you can stop and continue at any time, which is very convenient for medical staff who are busy. So they will be relevant for quality managers, they will be relevant for nurses, doctors, whoever, because they are very key basic things about quality improvement. So hope you will like them. Speaking about certificates, after today's event, we also issue certificates of attendance. You will get them. And you will get them not today and not tomorrow, but it takes time to make them, to create them. So please give us kindly this time. You will get them by the end of May, so approximately May 30th, May 31st, and you will receive them to your email with your name. Also, we kindly ask you, we're not saying goodbye yet, but kindly ask you to fill in the survey on exit after this event, because your feedback is very important to us, and it tells us how we need to change to make your expectations better. And now we're moving to Q&A section, and I think today we have a record in the number of questions, and I think it's going to be a very exciting discussion. And actually, some questions relate to specific things that were mentioned in the presentations of our speakers, but some are very kind of more generic. And probably we can start with a question which I think is also a very important question for every facility. It's patients being late for an appointment, how to measure, how to treat these patients, and what should be the policy on that. And no-show appointments, what to do with those. So what's your experience? What the advice you can provide? Any experience in your facility with that? So let's discuss this question as the first one.
Okay, Julia, how would you like us to answer these questions? Can we just unmute or?
Yes, please just unmute. Maybe Aisha, yeah, you can be the first, and then maybe Karina, and then Joe.
Okay. All right, then. Yeah, so I think it's a very important question because, of course, things happen sometimes, patients change their mind, a lot of things. But very importantly, you need to set up a system that sort of looks at, the lateness and also the no-show. In our facility, we've also given like a buffer time. So if someone says, they're coming in at 3 o'clock, we give like a 15 buffer time. But then before that, there are a series of, check-ins with this patient. So in the morning, we also would call the patient to confirm the appointment. I think that's a good, strong measure. So you can confirm if this person is still going to come at the designated time, or you may want to shift the timing. Also, there's also that follow-up a day before. There's a reminder. I think there are a lot of reminders because we understand how busy our patients can be, right? Yeah, so that's basically how that is really structured, and looking at ways to just sort of also communicate it. But of course, there's also a need to have that policy. The policy just allows even the physicians to understand how we manage this, of course, at the front desk, because most of the time, the patient facing people would be, at the front desk when the patient comes in. So how do we communicate that? And at the same time, whenever you have a policy, always communicate that with your patient. Do not just leave your policy in the clinic, because especially policies like this affect the patients more. So whatever measures, whatever information you need to share, use your mailing list, send those emails, call those patients, and then also just communicate, and then ensure that, you also sort of support them to ensure that they don't miss their appointments as well. So that would be what I'll be sharing. Thanks.
Thank you very much, Aisha. All super valuable things you mentioned. Karina, is it an issue in your facilities, no show or being late?
I believe that this is an issue in every facility because I cannot say I don't know any facilities in Romania that doesn't have this situation. For us, yes, indeed, we understand and we agree with Aisha. We understand that is most important. The most important thing is to remember to the patient that he has an appointment and make them understand that it's important for him. We have an electronic system that allows us to remind to the patient about the appointment, and then we call the day before in order to confirm that he is able to reach to the out clinic or in patient or the hospital department. But we also understand that there are situations that appear the same day. And we have some slots that are for each patient, and the patient is allowed to be late half of the slot. For example, if the slot is 20 minutes, he is allowed to be late 10 minutes. And the doctor explains then that or they cannot do the entire examination, or this is a consultation that may not solve all the problems. And the patient should come back in another day. So we try to help them and to understand even this situation. For no show, we don't have a specific rule, and we allow them to reschedule the appointment for another day.
Thank you. Thank you very much, Karina. This is also very, very valuable information that you provided. Joe, and the theory that you described, does it say anything about this very specific, very sensitive aspect?
There's nothing specific to no-shows and people coming in late. What I have seen others do is honest communication. You identify what we call the frequent flyers, those that are always late or always canceling or not showing up. And perhaps you analyze, is it a certain day of the week? Does a person always not show up on Tuesdays in the morning? And so, but you would have to have an honest conversation to talk about the importance of attending their appointment. The reminders are important, especially if there could be automated. I know some of the dentists in Canada, they use automated phone reminders. I'm not sure if that's available to people, but other than treating them with having an honest and frank conversation, and if it continues, there has to be a consequence, something that, is difficult because people say, well, the people that don't show up are the people that need our help the most. So why would we terminate their relationship with us? But anyways, it's a difficult situation for sure.
Yeah, definitely ethical. Yeah, I agree. But identifying frequent patients who do this, I think that's a great tip. A great tip, yeah, and also requires analysis. And today we are talking a lot about calculations and analysis, but that's definitely a very efficient tools in this sensitive matter of waiting times. So speaking about waiting times, we received lots of questions about specific times. For example, what durations, yeah, and what is the standard recommended measured time? Is there waiting time? Like, for example, Aisha mentioned 10 minutes, but how do we calculate something which will be reasonable for our facility, for example? Also, duration of the doctor's consultation. Today, we were already mentioning that it matters a lot and sometimes can be reduced to meet the growing demand. But is there anything standard in this regard? So let's talk about quantitative characteristics of various times now. Aisha, do you want to start, or maybe Joe?
Yeah.
Okay, Aisha. Yeah, I don't want to be
I think
pointing fingers. Yeah, please.
So I think I received a lot of questions around that, and then maybe that would be based on my presentation, and of course talking about our target of 10 minutes. But I think just what to clear the air is I don't think there's a standard time. And this is because every facility is very different from every facility. I mean, even you're talking about outpatient, it depends on your patient pool. I was reading a comment, and there's an outpatient facility that has about 2,000 beds. I mean, 2,000 bed compared to a facility like mine would be, you can't compare that to a 10 minutes. So basically, what you need to do is really get your data out. Your data would be what would confirm a standard time for your facility. And I would also advise that we always don't look at the smallest amount of time. We need to sort of speak to people that are actually part of the process. So even before sticking to a 10 minutes at EG clinics, we had to talk to the doctors, we had to talk to the pharmacists, we had to talk to the lab to understand their process, what happened step by step. Of course, looking at how we could remove some non-value added activities and maybe automate some of them, or maybe make it a more seamless way so that it reduces the time. But basically, there was a lot of criticality in looking at what that process looks like for them, and also questioning them and asking them, is 10 minutes enough for you to do this? Is 10 minutes enough for you to actually achieve what you want to achieve? We got a lot of questions even before getting the 10 minutes. Some doctors were like, oh, maybe when we have like an emergency. So we have buffer periods for things like emergency, things that maybe would need to allow them, maybe in terms you want to refer a patient. We have a lot of peculiar cases that would meet that. So in terms of standard, I think we need to be careful what we call standard and be a bit more practical with the way things actually run in the facility. So look at your processes, ask questions, work with your team members to then confirm what you would think would be a standard timing for your own facility. Thank you.
Thank you, Aisha. That's a great point. Let's go a different order. Joe, what would be your comment on this?
My comment is it's called continuous improvement. So your team first decides a target, and then try and make it better. I think Aisha's points are valid, that you can't pick a number out of the air. It has to be relevant to the context. So speak to the people who do the job every day. She talked about Gemba. It's a great idea to just sit in the clinic and watch, see what happens with the flow of humans through the clinic. Where is the delay occurring? Find out why it's occurring. But in terms of a standard time, there is no standard time. It's whatever belief your team of people have.
Yeah, excellent, excellent. Thank you very much. Corina, anything from you on this?
Yes, I can say that I agree, both my colleagues. We were in this situation of deciding the standards time a few years ago. We have a history. The network is 30 years in our country, so we have some history. Now we have a standardized time, but it wasn't from the beginning. We have the time is different on each specialty, and it different if the doctor has an ultrasound in the room. In our country, the doctor is responsible for ultrasound. So it's his responsibility. So if it's internal medicine doctor, gastroenterologist, for example, and some other specialties that need an ultrasound, so there we have a longer time. When we refer to specialties that don't need an examination, we have shorter time. But the time is the same all over the network, in all the outpatient department and outpatient department in hospitals. And also we have the same standardized time for kinetic, for dental. I've told you about our other departments. Thank you.
Thank you. Thank you very much. So I think these are all great tips. And I think just to conclude, of course, as I already said, there is now one size fits all, but team approach in your facility, working together and trying different options and then analyzing how it worked. Yeah, piloting maybe even in one department, then analyzing and then adjusting will be the solution that would fit everyone. Yeah, but results of this analysis, of course, considering your context, will be all different. Now going to be a tricky question because we are talking about emerging markets. Sometimes there are staff shortages. So how to manage that situation? That's in general. If there is staff shortage, and using Joe's terminology, demand exceeds the supply. And what if there are any outstanding situations with medical staff, doctors? For example, doctor is on sick leave suddenly, yeah, so there is no doctor for specific condition or disease of a patient, but there is growing demand, or doctor is being late. Yeah, again, for one reason or another, everything happens. Yeah, we are humans. So how do you manage these situations in your facilities?
My answer is
Okay.
easy.
All
I
right,
don't
so
know.
go.
Yeah, because you have no facility. I guess why. Thank you.
Yes,
Okay.
I will
Yes,
answer
yes.
to that.
Yes.
We have fortune that we have different locations. So we are a network and we benefit from this. So when we have in a location a doctor that is on sick leave or is out for a training, for example, because it happens too, we try to bring another doctor from another facility, or we use virtual clinic. We also have this, so it's easier to manage the situations. But if we have a situation that happens in 1 or 2 hours, so it's too late to bring somebody from another clinic, we also have some situations, for example, for gastroenterology. If it's only a consultation, we can propose to the doctor to be seen by an internal medicine doctor or something, in order to understand the severity of the disease. But if it's about consultation and the patient just want the one doctor and only, we try to after when the doctor comes back to grow the number of slots that are available for patient in order for all the patient to have access to that doctor. So if the doctor has 6 hours, we try to make them 8 for other patients to be seen. So
Okay.
some tricks.
Yes, yes, and all this is very useful, I must say. Yeah, thank you very much, Corina, for sharing. Aisha, anything from you on such situations?
Yeah, I think very interestingly, we do something similar to what Dr. Corina said as well. Because we have a lot of locations, so obviously you look at footfall as well. So some clinics are a bit busier than some on a certain day and a certain time. So how we work is we sort of explore those kind of opportunities. And what it allows you is you need to keep on being innovative as possible, right? Now we're also fortunate to have our own in-house EMR. So it also helps to in terms of interoperability, where a doctor from another clinic can actually see what's going on even all the way to the wait time that is happening in another clinic. All they need to do is click a button, they can see the time lapse, they can see the delays, and we can then use that to, if we need to put in like a telehealth consultation, for instance, if this patient does not necessarily have to come all the way to the other location, we can actually have another consultation happening with another doctor from another clinic, in the same clinic that this patient is in, right? So we explore options like the telehealth consultation. But of course, cases where, physical presence matters, then we need to tell the patient, okay, so we need to let you know that, this happens, and then, you need to see this doctor in another location, right? Also, very close communication with the patient, because when there's an appointment, you need to ensure that that patient understands what's happening at every time. So in case there are issues, you're able to communicate. This patient does not have to come in when he doesn't have a doctor. If the doctor, something has happened, you already have communicated before the patient coming in, just so that you also earn that trust, right? That this patient feels like they are very important, and you ensure that they don't waste their time. And then of course, if patients have like preference to doctors, to a particular doctor, we also communicate the availability. Also, obviously, around specialists, most of the time specialists don't come in, our specialists don't come in Monday to Friday. So we communicate the dates, the time, and we manage those appointments based on the availability of the specialist. So it's really just using practical insight and just being very innovative on your process.
Yeah, thank you very much. That's very, very important point. If you treat patient as your partner, value their opinion, and show respect, then you get more understanding even on outstanding situations. Yeah, when, for example, the doctor is not available or the doctor is being late, then if you respect the patient and communicate effectively, it definitely works. So we are running actually out of time. So thank you for staying a little bit longer with us, because we will take several more questions, just a couple more questions, because actually today is definitely a record number of questions we received. And then we will try to answer some of the questions in our community of practice on Facebook. So please join. So one of the questions was actually, I think, inspired by Karina's presentation, by the innovative approach to start with diagnostics and then visit the doctor. So the several actually questions on this topic arrived. How do you make sure and ensure that the diagnostic is right and enough for the doctor to make the diagnosis if you start with diagnostics first? And are there cases that the patient has to go again for some other tests in order to get a diagnosis? It's going to be a tricky question, I think.
Yes, thank you for your question. We take this into consideration when we changed the flow. And we have done it only with the standardized investigations, for example, EKG and spirometry, and we didn't have situations when the patient has to repeat one of these. We don't do MRI or CT scan or something like that. It's only standardized, and only investigation that are in 100% cases needed for the correct diagnosis.
Oh, okay, great. This is great. Aisha, did you ever use such methodology, or it's only Karina's unique invention in their network, or do you start with diagnostics? Because it's a very interesting solution, I think.
Yeah. So it's very interesting. And of course, if you're going to be innovative, you have to think about all the different ways to sort of, improve on your process. And yes, we actually tested this model, and it's similar to what Dr. Karina said. Of course, there are limitations to that, right? It can be for like, complicated cases or for like emergency cases. It should be just direct, so which is diagnostics, like she said, ECGs, spirometry, things that, can work faster. Also, what we had tried to do is also like things like annual health checks, right? Because we're primary healthcare facility, so they already standardized tests, for different age gaps, for different cadres. So someone that is, 65 plus, we already have like range of tests that this person can take before even seeing the doctor. Then you can go back and see the doctor. So usually that sort of help manage, all the things, because like things like fasting blood sugar, definitely, I'm waiting for my doctor, I could take out that, things like that. So there are standardized things that can be done, but then it can't really cover a lot of things. But then usually measures like this also helps to reduce the wait time.
Great. I think it really might be a breakthrough using this targeted wisely, of course. Yeah, but for specific widespread conditions, for sure, it might save a lot of time and increase patient satisfaction for sure. Just a couple more questions let's take. So one, we already mentioned that patients might be resistant to change, as Joe said, absolutely right. So what can we do about that? If we change, for example, schemes, like we start with diagnostics, it's quite a change for the patient. Yeah, sometimes they don't understand. No, I need to see the doctor first. Why should I do this? So how to approach this wisely? And then one more question.
When we changed this, we explained. So it was a matter of communication, because everybody should understand. Everybody, if, when we refer to our staff, understands the importance and then can explain. And if the patient wants to see first the doctor can also explain the importance. And we all know that when the doctor says something, the patient accepts easier the change than in other situations. So yes, it was a matter of communication, and we also tried to inform them, some of them, when they have the appointment. Please come 10 minutes early. You will be sent to a spirometry, for example, and then you'll see the doctor. So it's a matter of communication.
Thank you so much. Yes, this is great point, by the way, to invite doctors also to this communication. Aisha, anything from you on this, or do we move to another question?
So I think, just in summary, it's just a matter of communication, right? Just keep on communicating to your patient, make them feel welcome, and try to also publicize your wins as well, right? So for every time you make changes, right, always use those communication lines to sort of communicate with them. You can also have like the Kaizen boards and at the patient facing area. So usually we can have that at the front desk, or maybe also by the corridor space. It also allows them to read about the reasons why we sort of improve our processes, why we continuously improve. So once you have those visual communications, you also have the passive communication done. And very importantly, I also agree with Dr. Karina. Usually when the doctor says something, it's like they feel a lot better that it's coming from a doctor. So yes, always work with your, patient care providers also to have that same mode of communication and just be consistent in that. Yeah.
True. This is so true. By the way, Joe, I'm not ignoring you. Just speak up whenever you feel like. So one question before the last, we didn't mention today, only partially, call center. What role does it have? Because it's actually at the front, patient facing element. How can we use it to affect waiting times? Let's just very briefly discuss, and then we will conclude.
I mean, a call center, if their job is to receive people calling to make an appointment, then they have to understand the rules for scheduling. They have to understand the availability of all the healthcare providers. They have to understand, how long a provider wants the appointment scheduled. Is it 30 minutes? Is it 20 minutes? But the call center, the technology exists that you can, depending on how many agents you have, to minimize people waiting. Those are some early thoughts.
Yeah, thank you, Joe. Yeah, all very useful. We already mentioned confirming appointments. That's definitely their role. Yeah, also suggesting appointments instead of walk-ins, because sometimes calls are received just to confirm that the service is being provided, and the call center can just say, okay, do you want to make an appointment? So that we move patients from walk-ins to more structured flow. The message is, do not underestimate that element. Train call center properly and include them into your system of managing waiting times, because they are very, very important element. So I think I actually planned to have the last question on what advice you can give to our audience, but I think in your presentations, you already gave very useful advice where to begin work on measuring and managing waiting times, and where to start and how to approach this. So I would take this question away. We will not be talking about it. So thank you very much to our wonderful, wonderful speakers today for their practical advice and tips and sharing their journeys, which were not easy. Thank you so much for our wonderful audience today for being so active, asking so many questions. Please join, I just want to remind once again, our community of practice on Facebook. Links are in the chat. Please join EPIC, learn more about it. Also, link is in the chat. Please use our online training modules. Please continue visiting our webinars. We will announce topics later on, so please look up for our invitations. And hope to see you next time again. And I do hope that you enjoyed our discussion today. Thank you very much for great feedback in the chat. I saw all of it. So have a wonderful rest of the day, wherever you are located. Have a great afternoon, evening. Thanks so much once again, and see you next time. Bye-bye.
Thank you for the invitation. Bye-bye.
Thank you. Bye.